Thank you so much for the introduction and for inviting me here. I think I sound a little bit too loud, but you're going to have to live with that. So what I'm going to do is give you a very brief introduction and then talk to you about rotavirus in some detail and then typhoid in less detail. So if you want to make a decision about vaccines and whether they should be introduced in the country, there's two ways of thinking about it. One is when that is a disease that is normally prevalent in the population. And then there are special situations where you might see the disease. And those could be travel, outbreaks, occupational risk, etc. But what I'm speaking to you about is endemic disease. Now, in endemic disease, you have to show that there is a problem. You have to have a solution to that problem, and you have to have a system that is ready to deliver that solution. So what I'm focusing on is the first part, which is showing that there is a problem. Now in India, we are very good at setting up systems. So for vaccine preventable diseases, we have lots of systems. Some diseases actually have 5 different systems to measure the occurrence of that disease. The problem is that no 2 systems give you the same numbers. So it becomes really, really challenging to try and figure out, if we have a problem, how big is the problem? So I'll give you one example of where you had 2 government agencies investigate the same problem at the same time. These were diphtheria outbreaks that were occurring in 2017. We knew in general that there were outbreaks in the north and the south of the country because the newspapers told us that there was a problem. And then the National Centers for Disease Control, through the Integrated Disease Surveillance Program, did an investigation. And then the National Polio Program, which does not work on diphtheria or did not at that time work on diphtheria, decided that it would also investigate the outbreaks of diphtheria. I will leave you to figure out what happened, which figure came from which agency, but they were literally working in the same areas at the same points in time. So when it came to thinking about rotavirus and whether there was a disease burden of rotavirus, I think it's important to recognize that just syndromic disease tells you very little. Rotavirus is the commonest cause of dehydrating gastroenteritis in children, but there are 400 causes of diarrhea. So unless you investigate the diarrhea, you don't know what is causing it. So that's a bit of a problem. And there are many ways that you can look at disease burden as public health estimates. Some of them are, is the disease mild, moderate, severe? Does it cause death? And for most vaccine preventable diseases, up until recently, only the deaths mattered. Hospitalizations and mild disease did not matter so much. And then the other thing that matters is really costing. And then for some diseases, genotyping, which strain is circulating where, also matters, more for respiratory infections than for diarrhea. Now, for studying rotavirus disease burden in India, I started in 22 years ago. And the way we did it was to set up studies that were in the community and in the hospital. We also did a number of other studies shown in black, but I'm not going to talk to you about those studies. For the community-based study design, what did we do? We recruited women who were pregnant. We waited till their babies were born. We then followed up their babies by taking a stool sample every 2 weeks, whether the child had diarrhea or not. And then whenever the child had diarrhea, we collected samples. And those were then investigated for rotavirus and other causes. We genotyped the strains, we looked at immune responses, etc. We were working in a population that had lots and lots of children. It was a GIS mapped population. These kinds of studies are quite resource intensive to do. But what it allowed us to do is to look at the age at which children within the cohort got infected and the age at which they manifested with disease. In the first 6 months, children are generally breastfed, so you expect to have some protection from infection and illness. But in our cohort, half the children were already infected by the time they were 6 months old, and about one-fifth of the children had had disease by that time. By the time you got to 3 years of age, every child had been infected, and about half of them had had diarrhea. So we were able to establish the incidence of infection and diarrhea, and these can be outside of cohort designs, can be quite challenging to set up. We were also able to classify the severity of diarrhea, and we showed that the incidence of severe rotavirus diarrhea was about 5 per 100 child years of follow-up. We looked at severity in a number of ways and showed, as had been shown in other parts of the world, that rotavirus causes a greater proportion of severe diarrhea than it does of mild diarrhea. We could show that by grading the severity, we could show that by hospitalizations and where treatment was accessed. So to summarize all of our findings, after 6 years of studies, we were able to say rotavirus infects all children, that in India, infections and disease happen early, that you get a lot of reinfections in India and they are symptomatic, and rotaviruses cause a greater proportion of severe diarrheal disease and mortality than other diarrheal pathogens. We were able to back up this information by other cohorts that we studied and one other cohort that was studied specifically in Delhi. And that ability to have multiple sources of data allowed us to come up with an estimate of the number of episodes that happened in the birth cohort in India, and that varied from about 16 million to 39 million. So quite a lot of variability in the amount of infection. The variability got a little less when we looked at outpatient visits for rotavirus gastroenteritis across all of these cohorts, because here we went from about 5 million to almost 9 million. We also did a lot of work in hospitals where we set up this national network, and we looked at what was the proportion of diarrhea that was due to rotavirus in the hospitals. In the West, it's usually about 3 out of every 5 episodes are caused by rotavirus. In India, it's about 2 out of every 5, given that we have many more pathogens that cause diarrhea in our children. We were part of a global network, and doing measurements on multiple scales is very valuable because it allows you to validate what you are finding, to show that what you find in your particular setting is not different from what the rest of the world is seeing. So we were able to do hospitalization rates, and here you can see that hospitalizations were even closer than the outpatient visits, because the numbers were between 700,000 and about 1.1 million hospitalizations in the Indian birth cohort every year. We also applied estimates for mortality based on a number of different kinds of adjustments, and then came up with somewhere between 100,000 and 160,000 children dying every year because of rotavirus gastroenteritis. That allowed us to build a disease pyramid where we could say that half of all children were infected every year. 1 in 8 children needed an outpatient visit, 1 in 30 children was hospitalized, 1 in 650 children born in India would die of a rotavirus gastroenteritis. So if you want to convince policymakers for a disease, nobody wanted to introduce a vaccine for diarrhea in India, I have to tell you. So building this was an absolutely essential component of showing that there was a need for rotavirus vaccination in India. You can, to some extent, but fortunately for us, rotavirus infections are only vary in time, and not in the proportions of the population that it affects. So you will wind up with a very similar looking pyramid. In poorer populations, infections will happen in the first 6 months. In richer populations, they may happen 6 months later. But everyone will get infected. And serology studies show us that. So we also did costing studies to demonstrate that there was a significant economic burden. Rotavirus hospitalization resulted in about 5% of median annual household income. So 3 days of hospitalizations meant a lot of out-of-pocket expenditures for children. And outpatient visits were a tenth of that. So here we are, decision making for vaccines. We were able to demonstrate that there was a public health need, that India was not different from the rest of the world, and that we needed to introduce a rotavirus vaccine. So we also did work to make a vaccine, and in 2016, the vaccine was introduced in the program. Remember, I told you I started work 22 years ago? Took 16 years to get the vaccine into the program. But now it is countrywide, and we are doing an impact assessment for the vaccine. So that's one disease. Now I'm going to talk to you more briefly about typhoid. And typhoid is again another problem. Typhoid is a fever, right? Everybody recognizes, has heard of typhoid forever. Lots of people tell you that they have treatments for typhoid. But diagnosing typhoid is not simple. And the reason that diagnosing typhoid is not simple is because of the widespread use of antibiotics. When we started this out, we actually did a systematic review to look at whether typhoid was a problem in India or not, because in hospitals, you were not seeing typhoid. What the systematic review showed was that over time, the proportion of typhoid in hospitals was decreasing. So was there really no typhoid in the country, which is believable? Or was it being masked because of antibiotic use? You also had people in Delhi where there was typhoid vaccination. The doctors objected to the use of typhoid vaccine, saying there's no disease, we don't see it. The problem actually wound up being that the doctors sit in hospitals, most typhoid is treated in pharmacies. So we set up this study to look at typhoid, and typhoid diagnosis is very challenging because you have to do blood culture, and if you've been treated with antibiotics, it drives down the number of bacteria in blood, so your blood culture will wind up being negative falsely. So you have to look at that, and if you have antibiotics early in typhoid, you get decreased blood cultures coming to hospital, decreased sensitivity of blood cultures, and there might be a decrease in transmission also by decreasing infectiousness. The problem with typhoid with all bacteria is that there is AMR. There is extensively drug-resistant typhoid in Pakistan at the moment, and azithromycin-resistant typhoid in Bangladesh. Sorry. So we set up this study where we essentially did 3-tiered surveillance. I'm going to tell you about the first 2 tiers of surveillance. Essentially, we did a similar thing to what we had done for rotavirus, but we did it countrywide. We wanted to estimate the incidence of typhoid in children between 6 months and 15 years, following them up every week for fever and then making sure that they got blood cultures. And we also wanted to see, could we measure severe typhoid in the community across the country. Then we also wanted to look, obviously, at antimicrobial use, antimicrobial resistance, look at cost of typhoid, etc. Basically build the whole picture about what this disease really means for the country. So our tier 1 surveillance was 24,000 children in Delhi, Kolkata, Vellore and Pune that were followed for fever. And what we did there was we reviewed children, contacted families every week, reviewed children with fever every day. If they had fever for more than 3 days, they were called suspected typhoid fever, and we went in there and did a blood culture using an automated system and then figured out, was this typhoid or not? What did we find? We found that S. typhi was the commonest organism that we detected in blood cultures, and the incidence of typhoid per 100,000 child years was 500 in Delhi, 588 in Kolkata, and 1178 in Vellore. In Pune, which was a rural site, it was 38. I will remind you that globally authorities say that you have very high incidence. Not that you are endemic, but you are hyper-endemic if you have an incidence of over 200 per 100,000. So you can see all the cities or urban areas are very highly endemic for typhoid. Now, in order to look at severe typhoid, we went across the country. People told us, look in the Himalayas. So we went to Manali. They said, look in rural areas, tribal areas. We used Chinchpada Hospital in Nandurbar. We went to Karimganj district in Assam. We went to the Nepal border in East Champaran district in Bihar. We went to rural Andhra Pradesh, and we set up surveillance in all these places that had never done automated blood culture before. So we actually sent technicians out there and machines out there to do this surveillance. And the idea really was to characterize the clinical spectrum of typhoid coming to smaller hospitals in India where these kinds of studies are not normally done. So these were the hospitals, and each of the hospitals was referenced to the population that they served. And these populations varied between approximately 100,000 and 300,000. Now, because typhoid is complicated, you have to do some adjustments. You have to look at what proportion of typhoid hospitalizations in the catchment area you are capturing. How many of them get hospitalized at the surveillance site? How many of them receive a blood culture? And what proportion of blood culture is positive? Remember, I said if you've had prior antibiotic treatment, it decreases the sensitivity. So these were the adjustments that we did. And our incidence of typhoid is down here. You can see that Chandigarh, which was our only urban area, was again very high. And among the rural areas, it varied between 23 and 127 per 100,000 person years of follow-up. Now here, this is all ages. This is not 6 months to 15 years, as we had done for the cohort studies. Now, we used all of this data. We also had another tier of surveillance where we captured complications from typhoid. So I'm not going to go into that, but we used this data to model what would happen if we introduced vaccine. So what you have in the black line up here is status quo. And if you were to follow a policy that was to introduce the vaccine into just the urban areas, routine immunization, and do a campaign, this would be the decrease that you would see. So what we actually did was to model all kinds of introductions, because again, the program doesn't necessarily want to introduce a new typhoid vaccine until you show them what impact vaccination might have. So if we were to do a campaign plus routine strategy, effectively we could push the measurement of impact in the population back by about 4 years. So these data were presented to the National Technical Advisory Group on Immunizations, and this vaccine has now been approved for introduction. When the government will introduce this vaccine, I have no clue, but at least as academics, we have done our job. India actually has the only typhoid conjugate vaccines in the world. There is a Korean manufacturer that's making one now, but 2 of the Indian typhoid vaccines are WHO pre-qualified. They are being used in Pakistan and in 2 African countries, but they are not yet in use in the public health program in India. And Bangladesh and India have the highest levels of typhoid in the world. So I'm really glad the decision to introduce has been made. Now, I think one of the things that we work on is really making sure that people have access to public health interventions, and for that, measurement is absolutely critical. And I feel like, I've wasted about 20 years of my life trying to measure disease, and I shouldn't have to do this. There should be a public health program that actually does this measurement. But the problem is that in India, all surveillance is siloed. So getting access to that surveillance, having syndromic surveillance, what are all the causes of diarrhea? What are all the causes of fever? We don't have that information. And in order for us to be able to do a good job with either measuring burden of disease or measuring impact of infections, that's what we really need. So thank you very much.
Just curious, fatalities due to rotavirus infection followed by diarrhea, is it due to dehydration, in which case it could be solvable,
It's
at least the
largely
fatality?
due to dehydration, because the problem with rotavirus is that you get the diarrhea, but you also get vomiting.
Oh.
And when you have vomiting, you can't use oral rehydration. You have to have IV rehydration. And in a child who is dehydrated, their veins will collapse and starting an IV becomes difficult.
Okay.
Very nice talk. I'm just thinking how, you talked about 20 years of hard work. Of course, I think we would like to surveil more. And my question to all of us, and you, because you have experienced this, is how do we scale up? Because the number of pathogens are high. And at the end of the day, almost all agencies are limited on their budget. One of the things that we have started doing is using some ideas from information technology and information sciences. But I would like to take your view on this, because I think we want to do this, but it's a problem that is extremely large, and I don't know where to stop it.
Well, actually, I think modeling can help because it's easier to capture syndromes. So many fevers, so many diarrheas, etc., because that will come to clinical attention. But then you need sentinel sites where you can do a deep dive into the etiology of those syndromes. So what is appropriate? Which diseases require a geographic distribution of sentinel sites? What should the proportion of samples that you sample? When there is an outbreak, how do you intensify? When you see differences in pattern, then where do you get better syndromic surveillance? We all know there's a dengue season. When there's dengue season, clinicians will not test for typhoid.
Thank you for the talk. You mentioned a significant amount of investment in time to do the surveillance for rotavirus to make a case for eventually the vaccine. How did you hit upon rotavirus? There are several other causes of diarrhea. Can you maybe narrate a little bit about the journey that you took to get to rotavirus?
Okay, so I started off studying bacterial diarrheas because when you're taught in medical college, what you're taught as causes of diarrhea always starts with bacteria. And then when I looked, I found that actually bacteria were causing a very small proportion of diarrhea. And the reason people weren't thinking of rotavirus was because there was no testing going on. It was when we started testing for rotavirus, we found, in early poorly done studies that it was about 20% of all diarrheas. When we did the studies, better designed, better captured, getting in early enough, then we found it was actually about 40% of diarrheas. There is no other pathogen that causes 40% of all diarrhea. So we went for what is a common problem in India, and hopefully we've made a difference, because I'm told now pediatric wards, diarrhea wards are shutting down in many hospitals since the vaccine's been introduced. Rotavirus can be water and foodborne, but it's mostly person to person. So in fact, there are some very elegant studies from the US that showed that after rotavirus vaccines came into their national program, adult diarrhea decreased. So it was really parents of young children who had diarrhea that would get a high infectious load, develop diarrhea, and that diarrhea came down once their children were vaccinated. There were also age cohorts that had not received vaccine, and diarrhea in them came down by about 50%. So it is largely person to person spread, but can be food and water. Typhoid tends to be also the same, but the proportions vary.
How old should the baby be before giving a rotavirus vaccine?
Rotavirus vaccine can be given as a neonate, but there is a neonatal dosing schedule. The way it's used in India, it's given as 3 doses at 6, 10, and 14 weeks, along with the routine vaccines. It's an oral vaccine.
Oh.
So polio is 2 drops, rotavirus is 5 drops.
But only some states have this.
All states
All
have the
states, very
vaccine
good.
now.
Okay.
So it was in the private market from 2008 onwards. But for us to get it into the public system took us until 2016.
Okay. And I didn't know that, I thought typhoid was quite easy to diagnose by this Vidal test.
It's a
According to you, it is
huge,
not.
Vidal test is tossing a coin.
I see.
Yeah, it's a complete rubbish test.
I see. So, I mean, you have to wait. So what is the test? And
So blood culture is the only test. There have been a lot of attempts to develop better tests for typhoid, but they all depend on the input volume. And that's the problem, because the bacteremia is a very, very low level bacteremia.
Thank you for a very nice talk.
A small question. Are there new vaccines for these diseases nowadays which are more effective than the previous ones?
For rotavirus, there was an there was a subunit vaccine that was being developed. This year, the studies have been stopped because it was in a superiority trial and it didn't meet its endpoints. So we think better vaccines are required for rotavirus, but it's going to take a while to make them. For typhoid, the vaccines that we have now are so much better. I don't know about, some of us at least are old enough to have gotten the old TAB vaccines,
Yes.
horrible vaccines,
Yeah.
but these vaccines are really good.
So, are there policy initiatives which will bring them into the public health system?
Yeah, that's the ENTAGI. So we have really pushed. We've generated the evidence, we've got the decision, but the introduction is in the hands of the government. So, for me, vaccines are a tool for equity. If you get a vaccine into a program, that means the poor benefit. The rich have these vaccines anyway.
Thank you so much. So let's thank Professor Kang for a very illuminating